Welcome to the IVF Journey with Dr. Michael Chapman, the podcast for couples who struggle with infertility and want to fulfill their dreams of becoming parents. In this podcast, you'll learn actionable strategies to deal with infertility from Dr. Michael Chapman, or Prof as he's affectionately known. Prof is the co-founder of IVF Australia and is a leading Australian infertility specialist who has helped over 3,000 couples realise their dreams of becoming parents. To access previous episodes packed with ideas, solutions and tips that actually work, head over to Dr. Chapman's IVF podcast on iTunes. You can also ask questions by contacting Dr. Chapman's rooms on 1800 111 483 or by emailing him michael.chapman@ivf.com.au.
That first cry of a baby born after the long journey of IVF remains one of the most beautiful experiences in the world. As an obstetrician and an IVF specialist, I've had the privilege of experiencing this over many thousands of times in my long career, but I still remain moved by each baby's first cry. It signifies the end of a long journey and the beginning of a new life. So today we're going to talk about polycystic ovaries. Polycystic ovaries are the most common hormone abnormality that women suffer in the reproductive age. It affects something in the order of 5% of the population of females. The incidence of polycystic ovaries would appear to be increasing, and this increase is to some extent related to the increase in obesity in our general population. So what is polycystic ovaries? Polycystic ovary syndrome is defined as having features of extra male hormone, having irregular periods, and having on ultrasound a specific picture which shows multiple small cysts in the ovary. When the patient's told she has polycystic ovaries, that often creates fear in the sense of the notion that a cyst might be malignancy, cancer. So let me start by reassuring you that women with polycystic ovaries do not have an increased incidence of ovarian cancer. And what we're seeing on the scan is not ovarian cancer. The features in a classical case, and the problem with polycystic ovaries is it doesn't come in classical cases, it comes in a whole range of presentations. But the classic case is a woman who is overweight, who doesn't have periods, or at least has irregular periods, and is unable to conceive. These last two symptoms relate to the fact that ovulation, the making of an egg and a releasing of egg, does not occur on a regular basis. What causes polycystic ovaries is still unclear. I suspect someone at some point will earn a Nobel Prize because it's a condition that affects so many women in the world, and we still do not know how to reverse it. We can modify it to enable ovulation to occur. And probably more importantly, from a public health perspective, women with polycystic ovary have long-term issues to face. These include an increased risk of diabetes, high blood pressure, and earlier death. So it's a pretty significant issue. The thoughts about its causation go back to the time of puberty, because it seems that most women with polycystic ovaries have symptoms that began around that time. So as the female is maturing and her hormone messages from one part of the body to the other are being fine-tuned, it seems that that fine-tuning has gone wrong, that the normal default in terms of hormones feeding back on each other in the brain and the ovaries gets out of sync. And once it's out of sync, it generally always will be. It can be made worse by certain things. Stress is one, increased weight is another. So women with polycystic ovaries can improve their situation by reducing anxiety levels, but probably far more importantly, reducing weight. However, there are women who are slim who also have polycystic ovarian syndrome, and there are women with normal weight who have polycystic ovarian syndrome. So it's by no means universal that the classic picture that I just drew does occur. In an infertility clinic, I see many patients with PCOS, and in fact, as they come in the front door of the clinic, come and sit down in front of me, and I work out that they have polycystic ovaries, I actually like them the best of all my infertility patients, because I can be almost certain I'm going to cure their infertility. They are the easiest group of patients to get pregnant, because all we have to do is to get them to ovulate, which will turn them back into normally conceiving patients with a chance of 15% every cycle of conceiving. They often have other problems, ones that I've described above. For instance, excessive hair growth on their face, acne, and this irregular period, which very often is heavy. Dealing with those issues can be almost as important as their fertility issue. And certainly a general practitioner will see patients very often, not for fertility, but for these particular issues. Investigations of polycystic ovarian syndrome begin with a good examination. The doctor should be examining you to check for extra hair, acne. They will also then start organising investigations. Obviously an ultrasound of the pelvis to look at the ovaries, to look for that picture of follicles lining the outer rim of the ovary, which is the classic picture. In addition, they will do hormone tests, which will look at the pituitary hormones, that's the LH and the FSH. And in about 60-70% of patients with PCOS, there will be an elevation of the LH level compared with the FSH level. They will measure male hormones, and there are 2 or 3 of those that the body produces, some from the ovary, some from the adrenal gland, to check that these are in the normal range or just above. Because there are situations, rare situations, where a woman can look as though she's got polycystic ovaries but has more serious disease, a tumour of the adrenal gland or a tumour of the ovary. These are the basic tests. An additional test, because of the risk of diabetes, is to look at sugar levels in response to a glucose drink, where insulin is measured and glucose levels are measured. And something called insulin resistance can be identified. So insulin resistance is where the body isn't able to metabolize sugar as quickly as possible, and that then has the effects of increasing obesity. So we always check on that together with all the hormone background, not only to produce a diagnosis, but to give us a better idea of how we're going to treat the patient. How we treat the patient with polycystic ovaries is dependent on why they came to see me. So I do see girls in their late teens with irregular periods who aren't trying to get pregnant, but they are having great trouble with increased hair on their face and acne, which is obviously socially disfiguring. We deal with that situation by giving drugs that suppress male hormones. The contraceptive pill is the simplest of that, provided we pick the right contraceptive pill. And in about 60 to 70% of cases, acne and the excessive hair can be improved just by being on the right contraceptive pill. The next presentation is, I've mentioned already, of irregular heavy periods. Again, the pill can be helpful in that regard by regularizing the cycle. Obviously, the pill suppresses ovulation, so that's not going to be helpful if you're going to try and get pregnant. The third presentation, which is obviously the one I see in my fertility clinics, is that of not being able to conceive. And as I said earlier, that's primarily because regular release of an egg is not occurring. Polycystic ovaries syndrome does not necessarily mean that no eggs are produced, and I certainly see many patients who have all the manifestations of polycystic ovary who do fall pregnant spontaneously. But ovulating only 2 or 3 times a year certainly reduces your chance of conceiving. Treatment in this scenario aimed at producing ovulation is relatively simple. The drug of choice over many years has been clomiphene. Clomid is the name that most people talk about. This is a simple treatment. It's 1 tablet a day for 5 days, and ovulation should occur something in the order of 12 to 14 days after the first tablet's been taken. If it's successful, as it is in something like 80% of women who take it, who have polycystic ovaries, 80% will ovulate. And that will result, if they're patient, in a 6-month cumulative pregnancy rate of around 60%. That still leaves a number of women who don't get pregnant with Clomid. But the important thing is that Clomid isn't a magic drug. All it is doing by creating ovulation is putting the woman back to being normal. That normal rate of conception of 15% per cycle. Now that keeps going month on month on month, which gets our 60% mark. And if you go on for a year, should be up around the 90% mark. But most women do not want to wait that long. Most patients who come to see me want to be pregnant yesterday, and therefore they tend to move on to more aggressive treatments, which in many cases is unnecessary. A little patience and a continuance of clomiphene is perhaps a better way forward. There are patients who don't respond to clomiphene at all. There's something like 20% who, even with increased doses of 2 and 3 tablets, won't respond to treatment. They won't ovulate. There are 2 approaches subsequent to that. The first is an operation. By reducing the cells in the ovary that produce male hormone, there is a temporary improvement of the hormonal environment in the ovary, and spontaneous ovulation can occur. So we do an operation called ovarian drilling. So we do keyhole surgery with a very fine needle. We burn with electrical current part of the ovary away. It's a simple procedure, takes 20 minutes, and the pregnancy rate in the next 6 months without any other treatment is in the order of 50%. So it's not curative for everybody, but certainly one simple operation of ovarian drilling can be helpful to very many patients who have failed on clomiphene. The third option is to take over control of the hormone stimulation of the ovary. This is done by injections of FSH, follicle stimulating hormone, and the follicle stimulating hormone is what pushes an egg through to ovulation. So by giving injections of FSH, we're able to ultimately get ovulation in almost 100% of cases of polycystic ovarian syndrome. However, it does require injections, and more importantly, that FSH dose that we give may result in multiple follicles being produced, and therefore multiple eggs being released, and therefore, if those eggs are exposed to sperm, high multiple pregnancies. In fact, most high multiple pregnancies that make the front page of Women's Day or the Women's Weekly or whatever, most of those quads or quins are the result of this form of therapy, because we can't control the number of eggs that will be fertilized. What we can do in that scenario is convert those patients who have lots of follicles to do IVF. And by collecting the eggs and only putting one embryo back, we bypass the problem of multiple pregnancy. So in most situations, we can resolve that particular issue. If we go to IVF, and this needs to be the last form of treatment, if we've been unsuccessful with all the others, then IVF can be a tricky process in a woman with polycystic ovaries. In IVF, we're trying to produce multiple follicles. So we do give a generous dose of FSH, and in that scenario, women can overstimulate. And in fact, it's the women with polycystic ovaries who are most likely to get ovarian hyperstimulation syndrome. This is a situation where far too many eggs have been produced and the hormone levels are so high that we get changes in the vasculature in the blood vessels and make them leaky, and the leaky fluid gets into the tummy, and these women get swollen with fluid inside their tummy. This can be risky and has been reported that deaths can occur. So women with polycystic ovaries are very, very tricky patients to run through an IVF cycle and require highly specialised care. Fortunately, in the last 5 years, we have worked out a way of avoiding it in 99.9% of cases by using different medications at the time of the trigger to release the final maturation of the eggs, and by using a different drug from the standard that we've used for the last 30 years, we've been able to avoid most cases of OHSS. This is using an agonist trigger, using a GnRH agonist, which used to be used to suppress cycles, suppress ovarian function, but it has an effect on the pituitary of producing a natural surge of the LH hormone, which is what we mimic in normal cycles by giving human chorionic gonadotrophin, also known as Ovidril or Pregnal. So science has moved on, and to the benefit of our patients. So polycystic ovaries and infertility is predominantly solved by simple medication with tablets. But there is a group who need to move on through stimulation with FSH injections and natural intercourse. And there is a tiny group who then have to move on to IVF. So polycystic ovaries is a common condition. In general, there is a reduced chance of success in achieving a pregnancy, but for the vast majority, it's relatively easily dealt with, and many, many babies result with the simplest of hormonal treatment.
Thank you for listening to the IVF Journey with Dr. Michael Chapman, the podcast which helps couples negotiate their way through the IVF journey, all the way to parenthood. You can also ask questions by contacting Dr. Chapman's rooms on 1800 111 483 or by emailing him michael.chapman@ivf.com.au.